Hi, I'm Joe Graydon.
I'm Terry Graydon. Welcome to this podcast of the People's Pharmacy, where we bring you the stories behind the health headlines.
This podcast is brought to you by Redix Industries, makers of Utterly Smooth Body Cream. 800-345-7339, on the web at uttercream.com. More than a dozen diseases are transmitted by tick bites. Why are conditions like Lyme disease and Bartonellosis so controversial? This is the People's Pharmacy with Terry and Joe Graydon.
2 years ago, the CDC acknowledged that the number of Americans with Lyme disease is 10 times higher than earlier estimates. The agency went from 30,000 cases a year to 300,000.
Lyme disease is not the only debilitating infection that can be spread through tick bites. Bartonella often goes undiagnosed and untreated.
Alpha-gal allergy is another mysterious condition associated with tick bites.
Coming up on the People's Pharmacy, an update on diagnosis and treatment of tick-borne diseases from Lyme to alpha-gal allergy.
First, this news.
In the People's Pharmacy health headlines, testosterone may not be as bad for men's hearts as public health authorities have cautioned. The FDA recently warned that men who use testosterone replacement therapy are at higher risk for heart attacks and strokes, but 2 new studies contradict that conclusion. In one study, the records of 83,000 men treated at the VA hospital in Kansas City between 1999 and 2014 were analyzed. The men had been diagnosed with low levels of testosterone. Some of them had been prescribed replacement therapy to bring the hormone into a normal range. The average follow-up time was more than 5 years. The scientists found that men whose testosterone levels returned to normal upon treatment were 56% less likely to die during follow-up and 24% less likely to suffer a heart attack. The investigators concluded that normalizing testosterone in men helps protect against heart attacks and strokes and appears to prolong life.
Another report covered the results of a randomized controlled trial. More than 300 men with low testosterone levels were randomly assigned to receive testosterone or placebo gel every day for 3 years. The investigators measured the thickness of the carotid artery lining as well as the coronary artery calcium score. These measurements were stand-ins for atherosclerosis progression. In this trial, testosterone supplementation made no difference over the 3 years. Given that neither study supported the FDA's warning against testosterone, the agency may need to re-evaluate its caution about heart attacks and strokes.
When it comes to diet, saturated fat has been the number one public health enemy for decades. For years, Americans were urged to eat margarine instead of butter because margarine had no cholesterol. Instead, margarine had trans fats to make it solid at room temperature. A study published in BMJ this week reveals that the public health advice was totally backwards. The statisticians reviewed data from as many as 12 dietary studies, including more than 300,000 participants. They found no association between saturated fat consumption and the risk of premature death, heart disease, stroke, or type 2 diabetes. People who ate trans fats from partially hydrogenated vegetable oil were about 30% more likely to die during the study and 20% more likely to develop heart disease. Hopefully, public health experts will be more cautious about issuing dietary guidelines in the future so the proposed fix doesn't end up making matters worse.
Southern cooking, with its emphasis on fried foods, biscuits, and sweet tea, is hard on the heart. A team from the University of Alabama at Birmingham examined data from more than 17,000 people who were at least 45 years old. They lived in various regions of the country and were questioned about their dietary habits. The researchers found that people's food preferences could be characterized by one of 5 dietary patterns. One pattern included a predominance of convenience foods such as pizza, Mexican or Chinese dishes from fast food restaurants. Another was heavy on sweets with sugary breakfast foods and extra desserts. An alcohol and salad pattern emerged. It had lots of leafy greens and tomatoes, but also a lot of beer, wine, and liquor. The southern pattern included fried foods, processed meats, sugary drinks, and added fats. The final pattern had plenty of plant-based foods, including vegetables and fruits. In the course of 6 years, more than 500 study participants had heart attacks. People accustomed to eating a Southern-style diet were 37% more likely to be in that group.
Runny noses are among the most common health complaints of childhood. Swedish researchers conducted an 8-year-long study to find out if diet has an impact on this symptom. There were nearly 2,000 youngsters included. When they were 8 years old, the parents were asked about rhinitis from allergies or without allergies. The kids answered questions about what they ate. Approximately 1,600 kids did not have rhinitis regularly at the age of 8, but by the time they reached 16, about 20% of them had developed nasal allergies. About 15% had rhinitis that could not be traced to allergies. One item on the menu at age 8 had an impact on the likelihood of rhinitis at age 16. School kids who frequently ate oily fish such as salmon, mackerel, or herring were only half as likely to be sniffling and sneezing in their teens. And that's the health news from the People's Pharmacy this week. Welcome to the People's Pharmacy. I'm Joe Graydon.
And I'm Terry Graydon. Tick-borne diseases are widespread but can be difficult to diagnose and hard to treat. There's surprising controversy about conditions such as Lyme disease or Bartonella. Then there's something called alpha-gal allergy, which is triggered by the bite of a lone star tick. Today, we're going to get the latest updates on these tick-borne conditions and find out what makes them so insidious.
We're talking with Dr. Neil Spector. He's a medical oncologist, an associate professor of medicine, pharmacology, and cancer biology. He holds the Sandra P. Coates Chair in Breast Cancer Research at Duke University Medical Center. He co-directs the Experimental Therapeutics Program for the Duke Cancer Institute and is a Komen Scholar. His book is Gone in a Heartbeat, A Physician's Search for True Healing.
Dr. Spector, you're a specialist in treating cancer, but you have had your own experience with Lyme disease that led you to become pretty expert in this infection. Can you tell us a bit, please, about first your experience, very briefly, and also what we all should know about Lyme disease?
Sure. Yeah, thank you. I was misdiagnosed for 4 years, primarily because I didn't have the classic symptoms of Lyme disease, which, we usually think of as having the bullseye rash, having flu-like symptoms at the wrong time of the year, so in the summer when ticks are out, having arthritis, fever. I didn't have any of those symptoms. So I presented with cardiac symptoms, with arrhythmias, fast heart rate, slow heart rate, intermittent. About 5 to 10% of people actually have Lyme carditis, so Lyme infecting the Lyme disease or Borrelia, the bacteria infecting their heart. That's not the common presentation. So my doctors completely misdiagnosed the disease. I also had an episode of brain fog where I felt like I was walking in a cloud, which is also a symptom of Lyme disease because the bacteria can get into your central nervous system. So I was told that I had stress. I think a lot of people are told with Lyme disease that their symptoms are not related to anything other than stress because Lyme disease now can present in so many different ways and so many constellation of symptoms that it's often confusing. And unless doctors are thinking about it, they may not recognize it.
People don't always realize when they've had a tick bite, or if you live in a place where there are a lot of ticks, you may have so many tick bites, you might not be able to identify one.
Right. So that's another misconception, is that 50% of people don't have the classic bullseye rash. Depending upon your complexion, you may not even see it. Depending upon where it is, you can imagine if it's in your scalp, you're not going to see the rash. So 50% of people don't have that. And many people don't even have the classic flu-like illness, at the wrong time of the year. And if you're living in an area where your doctors and doctors in general deny that Lyme disease even exists, then you're really in trouble. So in North Carolina, when I moved here in 1998, I saw several tick-borne illness experts. North Carolina, we're more used to Rocky Mountain spotted fever. 1998, I was told Lyme disease absolutely, hands down, does not exist in North Carolina. I never, as a physician, as a scientist, when someone tells me this never happens, I have to immediately question the validity of that statement because, you could never say it never happens. Lyme disease occurs, I think, everywhere now. I mean, it occurs, yes, much more commonly in the Northeast and the northern
the upper
plains.
Midwest. Yeah,
but it occurs everywhere, and there are variations of the immune response that people mount to Lyme disease. Last year, literally at this time, the incidence, as quoted by the government, by the Centers for Disease Control, was about 30,000 new cases a year. From a Friday to literally a Monday, it jumped from 30,000 to 300,000 cases a year, and now being recognized as one of the most problematic infectious disease public health care crises that we have. So this disease is spreading. If anything, it's getting worse, and now people are talking about 500,000 people a year. So it's occurring not only in the Northeast and Lyme, Connecticut, and Westchester County, New York, but it's occurring in North Carolina and all over.
The usual statements about Lyme disease are, as long as we know about it right away, we can treat it, no problem. And the usual assumption on the part of physicians, I think, is that chronic Lyme disease never happens, right. Or something like that. Right. Can you tell us a little bit about what happens if Lyme disease isn't diagnosed and treated promptly?
Yes. So Lyme disease, the bacteria that causes Lyme disease, is rather unique in the sense that it finds what we call, hidden places where antibiotics aren't that effective. So it gets into your connective tissue, around your joints, the connective tissue in your heart, connective tissue in the brain. And those are sanctuaries. That's the word I was looking for. Those are sanctuaries where antibiotic drug levels generally don't achieve what we call therapeutic levels. And so the bacteria gets in, very smart. I mean, I don't know how it managed to figure out that that's an area, those places in the body where antibiotics aren't that effective. But it does. And so if you don't treat this disease early, some people say within 72 hours of the tick bite, and get the drug of choice, which is an oral antibiotic called doxycycline, it's very difficult to eradicate once it gets into those privileged sanctuaries in the body. Then it becomes much more problematic. You need much more aggressive antibiotics. This is where the debate between, the town and gown, the people in the ivory, league, the ivory towers, as we say, the academic medical centers, at one point were saying, well, you don't really need to treat this that aggressively, it resolves. And there were papers in very high-profile journals 20 years ago that said Lyme disease that infects the heart doesn't even need to be treated. It resolves spontaneously. So we've come a long way, but there's this friction between physicians in the community who are seeing the real Lyme disease cases and people suffering, and people in academic centers in the Northeast who are saying, those doctors in the community are over-treating. They're quacks. They're preying off of, this fear of chronic Lyme disease. You talk about chronic Lyme disease. So once it becomes chronic, people start to experience all sorts of debilitating disorders. Chronic fatigue. I mean, there are people who commit suicide. If you go onto the websites and support groups, there are people who have so much chronic pain from an infection, so they get treated, but they don't get better. What is that? Is that stress? Is that all in their minds? Do we need to treat people forever with antibiotics?
Well, the infection disease experts often say, well, it should go away after this course of treatment. And if it doesn't go away, it couldn't be chronic Lyme.
Right. Chronic Lyme disease, I don't think it's one category. We don't have the tests to figure out why people are suffering. Maybe in some people there is persistent infection and they do need to be treated. And anecdotally, there are people who take their antibiotics and feel better. And if they stop taking their antibiotics, they recur with their symptoms. There are other people who, again, I'm saying this as a scientist, more as a scientist than as somebody who's experienced Lyme disease. But there are other people who maybe have an autoimmune reaction to the Lyme disease infection, who probably don't need antibiotics forever, but we need to figure out how to treat them differently. Now, I say that it's interesting because there was a vaccine for Lyme disease that came out, and actually many people's pets still get it.
I was going to say, they have used it for dogs.
They've used it for dogs, but it was approved for people. It came out, and what happened when they were vaccinated? People got autoimmune disorders. They had symptoms that for all the world looked very much like people who suffer from this entity that we call chronic Lyme disease. Now, that tells me something, that if we're vaccinating people with antigens to try to protect them against Lyme disease, and they begin to suffer the consequences of literally an autoimmune disorder that for all the world looks like people who have been treated with Lyme disease but don't get better, that says to me that maybe those people are suffering from the body's reaction to the infection, not as an ongoing infection, but as turning the immune system against normal tissues for whatever reason. Maybe there's mimicry, maybe the antibodies or the immune response doesn't recognize the normal tissues as being any different from tissues infected with the bacteria. So I think the debate, it's become this very emotional debate on both sides. One side saying these people are malingerers and these people don't want to get on with their lives and they don't want to work and they want to end up on disability. I completely disagree with this. If you look at people who have worked all their lives, they were diagnosed with Lyme disease, and all of a sudden they've hit a wall and they're completely disabled. They're not malingerers. The other side says those doctors are trying to kill us. We need antibiotics for life. I think that we need more science. We need more research to figure it out, because I don't think it's a wastebasket of everyone with chronic Lyme disease needs antibiotics or everyone with chronic Lyme disease is a malingerer. I think that, like everything else, there's heterogeneity. There's probably people who do have persistent infections because this bacteria that causes the disease gets into areas that are very difficult to treat. I mean, look at what people have gone through. They've gone to hyperbaric chambers to try to increase the oxygen into those sanctuaries where the bacteria is, to try to increase the ability of the antibiotics to get there. I mean, people have gone to extreme measures to treat this disease. So there is a percentage, I believe, of people who probably do need long-term antibiotics. There are other people who long-term antibiotics is probably harmful to them because it's going to create resistance to other infections. And what they need is something very different that we don't quite understand yet how to treat. We need more science. We need, frankly, more money. I don't know that there's much money being spent on Lyme disease research. I mean, I'm in cancer research, and we're constantly complaining that there's not enough money for cancer research. I think the amount that the NIH, the National Institutes of Health, spends for Lyme disease is probably, a drop in the bucket compared to what it should be.
Dr. Neil Spector, thank you very much.
Thank you.
You've been listening to Dr. Neil Spector, the Sandra P. Coates Chair in Breast Cancer Research at Duke University Medical Center. He's a medical oncologist and associate professor of medicine. His book is Gone in a Heartbeat, A Physician's Search for True Healing.
After the break, we'll talk with Dr. Robert Mosiani to learn why Lyme disease can be difficult to diagnose.
Find out about Bartonella and why it's worth worrying about.
Dr. Mosiani will share his recommendations for enjoying the outdoors safely.
You're listening to The People's Pharmacy with Joe and Terry Graydon. If you're enjoying this People's Pharmacy podcast, why not head over to our website? Well, you'll find a wealth of information on medications, conditions, home remedies, and ways to keep yourself healthy. You'll find it all at peoplespharmacy.com.
Welcome back to the People's Pharmacy. I'm Joe Graydon.
And I'm Terry Graydon. The People's Pharmacy is made possible in part by Red X Industries, makers of utterly smooth creams and lotions that deeply moisturize to make dry skin feel soft and smooth. 800-345-7339. Online at uttercream.com.
If you'd like to order a CD of this show, you can call 800-732-2334. Today's show is number 1003. That number again, 800-732-2334, or find it online at peoplespharmacy.com.
Today, we're talking about tick-borne diseases. We're getting an update on the latest research that guides diagnosis and treatment.
Our guest is Dr. Robert Mosieni. He's a rheumatologist specializing in chronic inflammatory diseases with neurovascular as well as rheumatic manifestations. Dr. Mosieni is founder and executive director of the Translational Medicine Group and chief medical officer of Galaxy Diagnostics. He's also co-founder and medical director of the Foundation for the Study of Inflammatory Diseases.
Welcome to the People's Pharmacy, Dr. Mosieni.
Thank you. Glad to be here.
It's nice to have you back. Dr. Mosieni, you are a rheumatologist, but you have broadened your base, so to speak, and I'm kind of interested in how you got involved in tick-borne diseases. How did that happen?
Well, I've had an interest beginning in college and med school in immunology, having worked in transplantation immunology. And so in looking at choices for clinical careers, I wanted to be in a specialty that dealt as much as possible with autoimmune, inflammatory, and to the extent it contributes, chronic infections in mediating inflammation and autoimmunity. And so after a predoctoral fellowship at the NIH with the Howard Hughes Medical Institute, I changed career paths from a choice of surgery into rheumatology. And it was driven by my interest in the research of inflammatory diseases. And from there, I went on to do a research residency at Yale New Haven Hospital, where they had discovered Lyme disease a few years earlier. And so I hadn't planned on studying those things, but being at Yale where they discovered it, the rheumatology section in particular, which had discovered it, were the ones responsible for and running the Lyme clinic. And so in the course of that, I became interested in the degree to which rheumatic diseases could be caused by chronic infection.
Dr. Mosieni, we've spoken to a number of people like Dr. Neil Spector, who've had a great deal of difficulty actually getting a diagnosis of Lyme disease. What are the difficulties in diagnosing this condition? Why is it so hard?
So essentially the barriers to diagnosis, I think, are that the symptoms are highly variable. And so I always describe any disease that results from chronic infection as having a cause, which is usually, in this case, is infection, but it could be more than one. It could be varieties of infections, pre-existing infections compounded by new infections. And then there's the issue of the host response and then the environment. And so I call many of these host response diseases rather than infectious diseases. So if an infection is highly pathogenic, it gets noticed quickly, its causality is more clear. But if it's chronic, its causality is less clear, and the manifestations are more variable. So it creates confusion for the diagnostician, who literally feels like they're in a position of having to think of absolutely every possibility, every contingency. And there are many, 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 many microbes that could be tested for, and every one of those tests has major caveats. And so an appreciation of the list of tests that could be done and their caveats is pretty key. And I think this is a central technological limitation to the swift and accurate diagnosis of Lyme disease.
Dr. Mosieni, whether it's Lyme disease or one of these other tick-borne bacteria infections, what are the manifestations? I know it's different in different people. It's a big garbage pail of stuff. But give us a sense of what you see in your patient population when you're dealing with people who have a chronic infection.
The symptoms are, as you said, are highly variable, but they can include, first and foremost, fatigue. That's consistent in any condition that's associated with inflammation. They may have pain, arthritis. They may have neuropathic pain, neurological symptoms that could be unusual, ranging from a vibration sense to pinpricks to numbness and tingling. The common feature of all these inflammatory states is that you get inflammation throughout the vascular system, and that gets manifested when the inflammation involves the small vessels. And so when patients have these chronic inflammatory conditions, they have small vessel disease. We don't have good tests in medicine to measure small vessel disease. If you look at the skin, you might see patchy white areas we call livido-reticularis. That could be a sign that there's a microvascular flow disruption, and it's evident in the skin, particularly in very fair skin. But what I find is a very common feature, if one looks closely enough, are the neurological manifestations. So, for example, they would include tremors. They might involve problems with eye movement. So instead of the eye following a moving object smoothly, it follows it in a stuttering way. These patients sometimes report feeling very dizzy when they look at traffic in an intersection. Their eyes can't follow the car, so they tend to look down because it makes them dizzy. They may have a loss of balance. They, very often, along with this, they have executive dysfunction. And by that I mean you can't readily, or you do it with much effort, to sort, prioritize, coordinate your affairs. You might look at a pile of paper or a mess in a room and not have any feeling that you could actually address it. And it's not necessarily physical fatigue. It could just be that mentally you don't have good working memory or processing speed. And so you tend to avoid tasks where where you have to keep things in working memory to figure out how to prioritize, sort, and so forth. So these folks may not be able to balance their checkbook. All of this leads to a lot of extra effort, and that is driven by adrenal output, cortisol, and when that begins to fail, adrenaline. So then these patients have a higher level of inflammation, and that causes more symptoms in the brain. The inflammation in the brain is now a pretty hot topic because they're finally realizing that in whether it's Alzheimer's or these acute psychotic or rage episodes that many of these patients with infections have, that it all goes back to inflammation. They're even finding inflammation being a mediator of traumatic brain injury symptoms. It's a fascinating topic because it also opens up the door potentially to the appreciation that many psychiatric conditions have an inflammatory or infectious basis.
Dr. Mosiani, what is Bartonella and why should we worry about it?
Well, Bartonella is an example of a what we call a stealth pathogen. It's a microbe that is very prevalent. It has a slow dividing time, and it's not something that's going to immediately cause huge symptoms other than the initial lymph node enlargement that it could potentially cause, as well as some other symptoms in the acute phase. But because it's very prevalent, and because it's slow growing and potentially smoldering, it can infect people acutely, go dormant, and then drive chronic inflammation over time, potentially causing more inflammation, small vessel disease with various neurological, neurovascular, and rheumatic manifestations. Many of the patients we studied who had Lyme disease actually had a stronger exposure for Bartonella than they did for Borrelia or ticks. So specifically, they might have been exposed to fleas. They may have had cats who may have been infected and contracted Bartonella from their cat. And so, the more you look in nature, the more widespread you find Bartonella to be. And so we are finding that it's prevalent overall, but it's particularly prevalent in patients who have Lyme disease.
Dr. Mosiani, if I were to come into your office with complaints consistent with a tick-borne disease, I've got fatigue, I've got brain fog, and I also have a touch of arthritis that I didn't ever have before, and you suspect, well, yeah, it's a possibility. First, how would you test me? What kind of laboratory tests could you order? And B, depending on what you find, how would you treat me?
Well, when you come in with those symptoms, which I would call pixels in a picture, the picture I'm seeing is small vessel inflammation. And then the question is, what's driving that? I have seen patients with all the symptoms that you describe who have all their inflammation is due to a food allergy. And I've seen also those same patients with the picture you described have Bartonella or Borrelia. And so you have to, when you see that, you have to think small vessel disease and start looking at inflammatory markers. And you can't just look at the standard basic ones. You have to look at some of the more atypical ones. For example, we often find that the levels of C4A, it's a breakdown product of one of the steps in a pathway called the complement pathway, and it's what gets activated after an antibody binds an antigen. And so if you see elevated levels of C4A, that would be another clue that there's inflammation. C-reactive protein, the highly sensitive variety, has now established itself as a more important vascular risk marker than LDL cholesterol. So in men it's considered equally important, in women it's more, and in diabetics it's all important. So CRP levels that are even a little bit elevated should make one think about inflammation. And so even in cardiology now, in cardiovascular research, the thinking is now that arteriosclerosis is the result of a chronic smoldering infection. But nowhere is there a protocol or guideline yet to evaluate patients with arteriosclerosis for infection or to treat them. And you can only imagine how much worse this whole antibiotic controversy would be if that happened. So there's no question, we all need better ways, not just of testing, but also treating these germs without using methods such as antibiotics that create resistance. So that technological solution would also attenuate the controversy.
So I came into your office, you analyzed my situation, you ran a bunch of blood tests, you said, small vessel disease, inflammation, it's Lyme disease, or it's Bartonella. How would you treat me?
Well, I would start by looking at a number of what I call host response factors, as well as to establish which markers of inflammation we can use to monitor you. And so I would try to handle the easy, simple, less costly, less controversial things first. So it might be the elimination of a certain food to which you are sensitive. And then we would have a careful look at a panel of infection markers. If we found a high probability or highly certain finding, then we can work with that. But even when you do, you still have to deal with some of these host factors. Some of these host factors that are newly being evaluated include looking at methylation pathways. People with impairments of methylation may be hypercoagulable. If they are, even a low-grade infection can make them highly symptomatic.
What are your recommendations for folks who are, out hiking and boating and hanging out with their pets and being exposed to ticks and fleas and biting flies and all kinds of other vectors that might be carrying some of these nasty bugs?
Yeah, my advice is be active, but be prudent. Do your homework, at least do the basics of what it takes. Most patients who get sick don't even do the basics. For example, if you're going to go out where you might be exposed, use a little bit of insect repellent. We sometimes go out and watch my daughter's soccer game, and my wife gets bitten by these, small bugs around her ankles, and she may have a rash for a few days. I don't know what that is. It certainly makes me worry. But what can you do? So when we go to soccer games, we just spray down our ankles with a little bit of off. So I think you just have to be prudent. You have to be careful, but you can't be so paranoid that you don't live. Things happen. We live in a world of more than just us. There are plenty of microbes here, and a lot of them help us, a lot of them don't. It's about a balance. And then finally, it's about staying healthy. I mean, if you stay healthy, you greatly shift the odds in your favor. If you're stressed, your ability to adapt and manage inflammation is greatly compromised, and then you become highly symptomatic. So some patients don't recall a specific bite at all. They may have had the infection before, but they go through a major life stressor, which then depletes them and they get sick. And so, that's the flip side, is you just have to try to stay healthy because that gives you a natural resistance to the disease process.
And Dr. Mosiani, what symptoms should people be alert for to be kind of red flags that say, wait a minute, something is going on here. You need to be diagnosed correctly and treated appropriately?
Well, with many of these exposures, there is an initial illness. So in the case of Borrelia, it's the ECM rash. There may be other symptoms, a low-grade fever. If you get an insect bite, you should be concerned if you see the rash or redness growing or expanding. And within a few days or even a week or two later, you may get a febrile illness that's otherwise unexplained that doesn't really feel like a typical cold or the flu. And so if you see something like that, that's the best time to get it treated, but unfortunately, at those early stages, the test results may often be negative.
And finally, Dr. Mosiani, is there hope? I mean, do you have cases, patients who, had gone for a fairly long period of time suffering from what we'll call chronic Lyme disease or perhaps even Bartonella, and were able to get over this condition?
We get a very high percentage of these patients better, but it's a very difficult process for them. It's very costly. It's very emotional. And I think as a clinician, if you don't have your heart in it with the patient, it's really hard to stay with them long enough to get them well. So I think it's also an emotional drain on the practitioner. But there is hope. I mean, I regularly see people get better. And, what inspires me is how persistent these patients may be and how hard they try. It's usually the high performers who recover. It's the ones who are very diligent, methodical. They don't take no for an answer. They look around for explanations. And if they can stick with it long enough, they get better.
Is there a take-home message for our listeners, Dr. Mosiani?
The take-home message is you need to be very careful and analytical and thorough in the diagnostic testing. The right diagnostic tests have to be done. They should be done as many as possible early in the process of evaluation, because ultimately it saves time and helps greatly narrow down the specific treatments that have to be deployed so that we can actually begin to see which protocols work best in which categories of germs.
Now, as we're talking about the importance of diagnostics, I do need to ask you about conflict of interest, because, as we've noted, you are the Chief Medical Officer of Galaxy Diagnostics.
That's true. The research we did predated the formation of Galaxy Diagnostics. And by the time we recognized the public need, the research had been done. And because I had the experience, I was asked to join Galaxy as the Chief Medical Officer.
Dr. Robert Mosiani, I want to thank you so much for joining us on the People's Pharmacy today.
You're very welcome. Glad to be here. Thank you.
You've been listening to Dr. Robert Mosiani. He's a rheumatologist specializing in chronic inflammatory diseases with neurovascular as well as rheumatic manifestations. Dr. Mosiani is founder and executive director of the Translational Medicine Group and Chief Medical Officer of Galaxy Diagnostics.
Coming up, we'll talk with Dr. Thomas Platts-Mills about alpha-gal allergy.
How did Dr. Platts-Mills discover the connection between tick bites and an allergic reaction to eating meat?
We'll get Dr. Platts-Mills' recommendations on recognizing alpha-gal allergy and what to do after a diagnosis.
You're listening to The People's Pharmacy with Joe and Terry Graydon.
If you like the information you hear when you listen to The People's Pharmacy, you may also enjoy our book published by National Geographic. It's The People's Pharmacy Quick and Handy Home Remedies, available online at peoplespharmacy.com or at your favorite bookstore. Welcome back to the People's Pharmacy. I'm Joe Graydon.
And I'm Terry Graydon. The People's Pharmacy is brought to you in part by Red X Industries, makers of utterly smooth foot cream with shea butter, helping dry, cracked feet feel soft and smooth. 800-345-7339. Online at uttercream.com.
To order a CD of today's show or any People's Pharmacy broadcast, you can call 800-732-2334. Today's show is number 1003. That number again, 800-732-2334. Available online at peoplespharmacy.com.
We're talking today about conditions associated with tick bites. One that has been quite perplexing is called alpha-gal allergy. It can lead to life-threatening anaphylactic shock. We talk with the researcher who discovered the link between this mysterious allergic reaction and the bite of a common tick.
Our guest is Dr. Thomas Platts Mills, professor of medicine at the University of Virginia. He's the division chief for asthma, allergy, and immunology.
Welcome back to the People's Pharmacy, Dr. Platts Mills.
Oh, it's a pleasure to be back.
It's so nice to have you on the show. And Dr. Platts Mills, we spoke to you in 2011 about your alpha-gal allergy research and how the reaction to a bite from a Lone Star tick could lead to a delayed anaphylactic reaction to eating meat. Now, in those days, nobody ever heard of that. It was a total shock. I think a few more people are aware of it, but it's still pretty mysterious. So could you give us a little bit of the background behind alpha-gal allergy and what it is?
Yes, a pleasure. We already knew about these cases who described delayed reactions in our clinics, but we had no idea what they were talking about. And their prick tests, the ordinary skin tests to food, were negative, so that none of it made sense. And we were quite friendly about it, but we didn't really believe them. And then we were asked to investigate reactions to the monoclonal antibody cetuximab, which was occurring in the same area, but we had no reason to connect the two. And to make a long story short, we worked out that the reactions to cetuximab were occurring because of IgE antibodies in the serum of the patients before they ever got an infusion of the monoclonal, and those IgE antibodies were specific for the sugars on the monoclonal, and the key one was galactose alpha-1,3 galactose, or alpha-gal. And it's always known as alpha-gal in our world. And then we found that the patients with delayed anaphylaxis had IgE to this same sugar. And that left us with the question about why people in Virginia, North Carolina, Tennessee, Arkansas had this antibody when people in New York did not, when people in Boston did not. That led through ultimately to thinking about ticks. And actually one of the key things that put us onto the idea of ticks was that the area where it was happening was the same as the maximum area of Rocky Mountain spotted fever, which of course is a tick-borne disease.
Now, cetuximab is a cancer treatment, and so there were some oncologists who were quite puzzled as to why their patients would be reacting to badly and in a delayed fashion to this new, at that time, cancer treatment when they'd never had it before, right?
No, let me correct one thing you said. You're quite correct. People, including Bert O'Neill at UNC, had published a paper in the summer of 2007 saying that we're seeing a lot of reactions to cetuximab. That the thing that you didn't get quite right was that when the infusions occur, the reactions occur rapidly. It's the meat reactions that are delayed. If you put this oligosaccharide, alpha-gal, into the bloodstream in the right form, you can cause reactions, including very severe reactions, within 10 or 15 minutes. If you feed meat to the same person, the reactions take 3 or 4 hours.
So how did you stumble on this meat allergy thing? And it's still somewhat puzzling because there are people who are so sensitive that just driving past a barbecue, I've been told, can trigger this anaphylaxis type reaction. So fill us in on, is it beef, pork, and chicken? Maybe even lamb?
No, remember that galactose alpha-1,3 galactose is a blood group substance of the non-primate mammals, so that it's beef, pork, and lamb, not chicken, turkey, or fish. So that some of the patients will come into the clinic and tell us that they're reacting to beef, pork, and lamb and don't react to chicken, turkey, or fish. Most of the patients are a bit like me. I don't get reactions without a decent amount of meat. But you're quite right. Some of the patients are exquisitely sensitive. And we recently saw someone who was really challenging, and we're still not sure about, who'd eaten 2 gel caps of Aleve. The gel caps contain gelatin, and gelatin can carry alpha-gal. And 6 hours later, she got a reaction. But her titer is low. And we're really not sure whether that's the full explanation of what's happening. And so that kind of cases are accumulating in our clinic. But the truth is that most patients, it takes a decent amount of meat. So unless you eat half a hamburger, you're not going to react. But the exquisitely sensitive ones do create the clinical problem.
Now, Dr. Platts-Mills, did I hear you say that you yourself have alpha-gal allergy?
Yes, I'm afraid it's true. I'm a magnet for the seed ticks of the Lone Star tick. The Lone Star tick is very striking. It appears to be the only tick in the United States where the seed ticks, which are the first larval state, will bite humans. That is, for the deer tick, that's Ixodes scapularis, which carries Lyme, the larvae don't bite humans, and it's very unusual to get multiple tick bites. Whereas with Amblyomma americanum, that's the Lone Star tick, it's common to get multiple, and in my case, I've had hundreds at a time. I'm an enthusiastic hiker, and I actually love being off trail. I like the idea that there are not only no people there, but there never will be. And I get multiple tick bites, and then my levels of IgE, that's the allergy antibody to alpha-gal, can go very high, and I do have reactions.
I don't suppose we have any real understanding as to why there's such enormous variation among people from someone like you who has been bitten multiple times and does have an alpha-gal allergy, but needs a pretty big exposure to actually experience the allergic reaction, compared to someone who is extremely sensitive and actually reports that they may react even if they are exposed to cheese or milk.
Correct. No, that needs to be stressed, that I can drink milk and I can eat cheese and I don't have trouble. Other people clearly have bad reactions with cheese and milk. And we haven't done enough challenge tests to get a hold on that. But I think the striking thing from my point of view is that those people, it still takes 2 or 3 hours. It's not immediate. That is, the classical characteristic of an allergic food reaction was that it occurs in 20 minutes, so that if you're allergic to peanut and you accidentally eat peanut in a restaurant, you will not get out of the restaurant before you know you've made a mistake. Whereas with this delayed anaphylaxis, I've never heard of a patient who knew they were in trouble before they left the restaurant. It always happened later that night or later in the day somewhere else. That made it very confusing.
And that's why it was so hard for emergency physicians to understand what was going on, because people would show up in the ER at 3 or 4 o'clock in the morning. They were fast asleep until this thing started happening.
Absolutely. And if you ask the standard questions about anaphylaxis, have you had a bee sting? Have you been given a new medicine recently? Have you eaten something? Those 3 questions, they'd always be negative. The patient would say, no, I haven't had anything. I've been asleep for 3 hours, and I last ate at 9 o'clock in the evening, and it's now 2 in the morning, and I'm covered in hives. And that's exactly like me. I mean, if I would eat lamb at 9 o'clock in the evening, and about 3 in the morning, I'd be covered in hives. And let me stress this. I do not get anaphylaxis, don't feel woozy. I can stand up, my blood pressure's fine, but I just get hives. Some people get really challenging reactions and need emergency treatment.
Dr. Platts-Mills, I wonder if you'll bring us up to date on the research that has happened about this since the last time we talked back in 2011.
There are several things going on. One of the main things is we've been looking at the tick bites themselves, trying to look at the histology of what happens at the time of a tick bite that is associated with an increase in IgE, and compare it to tick bites where there is no IgE response. And it took some time to get human approval to do that, human investigation approval to do that. But we have it, and we've been doing that. And there clearly are the relevant cells accumulating locally in the skin. And we're asking questions about how B cells respond to this tick to turn on this IgE response. And you can actually clone the T cells, you can sequence the B cells and look at their sequence of their IgE molecules. And that approach is beginning to tell us how this happens. But I'd love to know whether it's happening in the skin or whether it's happening in the draining lymph nodes. That's one process that's going on. The other thing is we've looked at 400 cases of people who've had an acute episode, of whom 250 were classed as anaphylaxis. So 250 cases of anaphylaxis, and we're looking at the age of onset, the relationship to tick bites, the number of them who were allergic beforehand, and it seems pretty clear that half the patients had an allergic history or have IgE antibodies to things like dust mite and grass and ragweed, which have got nothing to do with alpha-gal. And they have allergy antibodies, then they got the tick bites and they developed this disease. Other people have no other antibodies at all, never had allergy before, and then suddenly at age 60 they get tick bites and they become allergic to red meat. And so that it appears to be not discriminating between allergic people and non-allergic people. It seems that all sorts of people can do this. But we also know there are people who can get tick bites and don't get this response. Either they get bites from another tick, or they get bites and just don't do it for genetic reasons. We're not clear about that. We'd love to know more about the genetics, and there's a plan to do a much bigger survey on a large cohort where genetics has already been done.
Dr. Thomas Platts-Mills, can you give our listeners some recommendations? Number one, how to recognize if they actually are developing an alpha-gal allergy, and then number two, what to do if they are diagnosed with this problem.
If you live in the area where this is common and you get tick bites, so that's from southern Missouri, eastern Oklahoma, Arkansas, Tennessee, North Carolina, Virginia, but also the states around those.
Well, and in addition, we hear that this Lone Star tick is expanding its range, so they're beginning to be seen even in places like Minnesota.
Yeah, I'm not sure I understand the Minnesota ones yet, and I haven't seen enough data about those. But what we do know is it's gone way up the coast, so that the northern end of Long Island, where there are a lot of deer and a lot of ticks, the allergist there, Erin McGinty, has seen over 100 cases. Whereas if you go to the southern end in Brooklyn or Queens, the allergy clinics there have never seen a case. But that's because no self-respecting tick would live in New York.
Right.
No, it's definitely spreading. It's not spreading straight into the country as fast as we thought it might, but we've definitely got cases in Pennsylvania now. And we all thought it was spreading because of global warming, but of course the deer tick is moving south and the Lone Star tick is moving north. I doubt it's both of them due to global warming.
So what should people know and what should they do?
I'm sorry. If you've had tick bites and you live in this area and you get a reaction, if nothing happens, I don't think people should be unduly worried. If you get any kind of food reaction or you get an outbreak of hives, as part of the investigation, you should be tested for alpha-gal, IgE to alpha-gal. The assay is available through IBT, so that there's a laboratory that can do it routinely, commercially for allergy practices. And if you've got a high level, then you should consider reducing your exposure to red meat, but you don't need to avoid milk. If you've really got the diagnosis, if you had a reaction, then you really need to avoid red meat. Whether you need to be scrupulous about avoiding everything else is a different issue. We don't normally recommend that people avoid cow's milk or cheese unless they've had a reaction or they're really having trouble all the time. Occasionally we see cases who you'd regard as chronic hives who are very badly out of control and where alpha-gal is playing a role. And the patients who are reacting to cow's milk may be drinking it every day and then they can have reactions, but they're clearly a minority of the cases. In most cases, these are isolated, separate episodes, and avoidance of red meat is easy. For me, it's been no problem at all. I avoid red meat fairly carefully, but then I have a cardiologist who's telling me to do that anyway.
Dr. Thomas Platts-Mills, thank you very much for talking with us on the People's Pharmacy today.
No, my pleasure.
You've been listening to Dr. Thomas Platts-Mills, professor of medicine at the University of Virginia. He's the division chief for asthma, allergy, and immunology. He joined us from the studios of Radio IQ in Charlottesville, Virginia.
Earlier in the show, you heard from Dr. Neil Spector of Duke University Medical Center. He is the author of Gone in a Heartbeat, A Physician's Search for True Healing. There's a link to his website from our website.
We also spoke with Dr. Robert Mosieni, co-founder and medical director of the Foundation for the Study of Inflammatory Diseases.
Lynn Siegel produced today's show. Russ Henry engineered it. Dave Graydon edits our interviews.
The People's Pharmacy is produced at the studios of North Carolina Public Radio, WUNC.
The People's Pharmacy theme music is by B.J. Liederman.
The People's Pharmacy is made possible by Redx Industries, makers of utterly smooth Extra Care 20 cream with 20% urea for extra skin protection. The number's 800-345-7339, online at uttercream.com.
If you would like to order a CD of today's show or any other People's Pharmacy broadcast, you can call 800-732-2334. Today's show is number 1003. That number again is 800-732-2334. Or you could always place the order on our website. It's peoplespharmacy.com.
When you visit our site, you can check out prescription drugs, benefits, risks, side effects, and other kinds of breakthroughs, herbal medicines, as well as home remedies. You can also share your own experience and thoughts about today's show on ticks.
Why not sign up for our free online newsletter or the free podcast of the show? You'll never miss another People's Pharmacy program, and you could share it with a friend. It's all there at peoplespharmacy.com.
In Durham, North Carolina, I'm Joe Graydon.
And I'm Terry Graydon. Thank you for listening, and please join us again next week.
We hope you enjoyed this podcast. If so, please consider taking a minute to write a review on iTunes. And thanks for listening to The People's Pharmacy.